Hello, everyone, and welcome back to our podcast, Pathogen to Infectious Disease Diagnosis, where we bring the connection between the lab and the clinic together to discuss how the latest generation of testing can help identify pathogens, to get a diagnosis, and harnessing potential partnerships between those laboratory professionals and infectious disease providers. Today, I'm excited to welcome Dr. Kyle G. Rodino. He is an assistant professor of pathology and laboratory medicine at the Perelman School of Medicine at the University of Pennsylvania and serves as the assistant director of the Clinical Microbiology Laboratory and director of the Rittenhouse Molecular Laboratory at the hospital of the University of Pennsylvania. His work focuses on advancing clinical microbiology diagnostics, including molecular and sequencing-based approaches for infectious diseases and diagnostic stewardship. Welcome, Dr. Rodino. I am excited to have you on the show. I'm especially excited to talk about the topic that we're going to be focusing on today.
Yeah, thank you so much. It's great to be here with you on this podcast.
You bet. So we'll just jump right into it. Can you talk a little bit about, do you see Lyme disease continuing to be our greatest vector-borne disease burden in the United States or with climate change? And do you see other diseases coming into the forefront in that kind of area?
Yeah, that's a really great question. It's hard to have a crystal ball into this, how things will change. But as far as tick-borne things, I think we're going to see Lyme disease remain our top tick-transmitted infection for some time, particularly because I think the population that's exposed to ticks is always changing, but you do need to be in a sort of, relative outdoor environment and doing things that expose you to those types of vectors. I think something really interesting to think about, though, is whether or not Lyme disease will be our top vector-borne illness in the U.S. And that means we have to start considering more about mosquitoes. So I think there is a concern, as we've seen over the last couple of years, we've had some mosquito-borne illnesses show themselves reemerge in the United States that we have not had for a number of years. We've had maybe the number's up to 13 autochthonous malaria cases across 4 states or so at this point, after eradicating malaria decades ago. We have dengue being transmitted, we know, in California and other areas of the South. And we have all of the vectors in the US to see a bloom of these pathogens. So I do think that's a thing to keep an eye on. How quickly something like that would change, I'm not really sure, but I do think when we talk about mosquito-borne illnesses, particularly where those mosquitoes can end up, kind of being everywhere and people are relatively exposed to them all of the time. You don't have to be hiking in the woods and playing in tall grass and those sort of things. That does create the opportunity for some of those pathogens to maybe emerge as bigger players in the US than they have been for years and years.
Yeah, right on. And you probably know I'm here in Texas, and I mean certainly since you mentioned it's interesting because I have other colleagues that are kind of in the vector-borne area of infectious diseases, and they're talking about yellow fever as well.
Mm-hmm.
Certainly the vectors are back, and part of that we believe is due to warming and those vectors kind of expanding their geography. It's kind of interesting to think. A lot of people don't realize malaria, for example, used to be endemic in many parts of the southern U.S., and we kind of pushed it away. And now it may be arriving on our shores again.
Yeah,
More
there's lots of old maps with covering a large swath of the United States that was malaria endemic, and that's true. Yellow fever you mentioned, malaria, dengue,
you know, Zeke
even
is
in
already
areas
here.
like we think of, people would call, Pennsylvania and Philadelphia sort of too north. There's some nice plaques over sort of where I live in the old city area of town that outline where there used to be marshland, and lots of people that first came here were at risk for those mosquito-borne diseases. So I think the potential geographic impact is wide.
Right on, right on. So when you think about those types of diseases, including tick-borne diseases, in all of the diagnostic options out there, right? So we know there's a lot of things going on in the molecular world and things like that. How can laboratories really ensure appropriate test stewardship and avoid unnecessarily or maybe poorly timed testing around those types of diseases?
Yeah, that's a huge challenge for the laboratory,
For
right?
sure.
So, particularly when you operate within large health systems, people presenting with tick-borne or vector-borne illnesses can show up pretty much everywhere, right? They
Right.
can show up at their primary care physician. They might show up at the emergency department. They may or may not be admitted. So really you have to have a system that allows optimal ordering no matter where that person enters for their healthcare. That's where it gets really challenging too, because not only does it have to work all the time across all of those places, but you may have a colleague that's a really great ID physician who's up on all of the newest and the best way to diagnose vector-borne illnesses, but that's not the interest and primary focus of most
Right.
of the physicians that are in practicing in the system. So you also have the challenge of getting that information to people as they order, and they might not be so versed in tick-borne diagnostics as maybe you, me, and the rest of the people listening to the podcast. So
Right.
that's really
Right.
challenging.
It really is. I'm actually working on an article right now, which is talking about, I'm sure you would agree, it's kind of an interesting time and kind of an unfortunate time because what we know is that not only clinicians, but many laboratorians that have never seen, some of these. So even in the scheme of tick-borne and other vector-borne diseases, they're now worried about vaccine-preventable diseases, right? We don't always see measles or mumps or rubella or things like that. So it's just I think, a difficult time for everyone involved.
I
Um,
think so. The things though that you can do. So I mean, it really comes down to the patient's timeline, right? When they were potentially exposed and
right.
what phase of their illness they're in, which dictates the best method in most times. You need to know a little bit about the patient because a lot of the diagnostics are serology based. And if that patient is immunocompromised and they can't produce antibodies, you might change your diagnostic strategy. And then you know to know a little bit about geography of tick-borne diseases, right? To pick the right things. So, but in the traditional way, the way labs can do that, they can have really nicely descriptive and verbose like lab test services guide where you can give some key point information. So if someone chooses to go look like what is the workflow for this? Maybe you have a nice flow chart based on time, a couple little, asterisks, caveats or bullet points of pertinent information. I've seen a lot of people starting to put that into the info box of their EMR. So usually when you click into an order in the medical record, there's a box at the top where you can put some of that extra information that you'd like people to consider before they click sign. So they've done that. But I think the really interesting thing is sort of taking these questions and embedding them into. So hopefully in the future we can have a smarter ordering system that can bring the expertise to the person when they're actively ordering.
Interesting times, I think, for infectious disease doctors for sure. With that in mind, why do you think the multi-pronged diagnostic approach, right? A lot of us were classically trained on microscopy and things like that. So when you combine microscopy and molecular testing and even serology, which you just mentioned, why is that still necessary, you think, for many tick-borne infections, despite all these advances in these new technologies and toys in the molecular world? Some of it still matters, right?
Absolutely. Some of the, like you mentioned, microscopy is still what I would call the gold standard for Babesia diagnosis and
Right.
percent parasitemia. I mean, we have seen the emergence of molecular methods for that, and they do perform well in the acute phase, but they're not at the fingertips of everybody. They're a send out in most situations. The timeline is extended, so they're not ideal in current state. And then serology really doesn't get you to the acute phase in Babesia infection and might just give you indication of past exposure or whatnot. So, yeah, I think we have a multi-pronged approach because there's no one single perfect test. And all of these different tick-borne or vector-borne pathogens might be carried by similar vectors, but they don't behave and they certainly can't be diagnosed in the same way. So really, we piece together what's best based off of the timeline and the patient. And if you want to paint it in broad strokes, I would say in the acute phase of a tick-borne disease, the microscopy for Babesia or the molecular methods for, say, Anaplasma, Ehrlichia, Borrelia miyamotoi, we're really looking at these direct detection type methods in the first 7-10 days of symptoms, mostly because the immune system hasn't had the opportunity to produce antibodies. So those serologic assays don't catch people in this most acute window. Can be useful to set the baseline of where they are from a prior exposure, but really not great acute phase diagnostics. And then once you
Right.
get past that 7 to 10 day window, serologic diagnosis becomes preferred in many of the situations. Sometimes the microscopy is not the best, or people sort of recover from their infection and there's not a ton of organism there for the PCR test to perform as well as we expect them to. And then we're really using those convalescent sort of samples to say, oh, you did have you did have Lyme disease in the last period of time. I think even though we have had significant technological advancement, mostly in the molecular space, but also in some refined antigens that are the basis of the serologic things, they still continue to complement each other. They do not replace.
They really do. I love hearing you talk about this because one of my favorite, I teach at Texas State University in the medical laboratory science program, and I do medical parasitology every fall. And one of the most interesting things to kind of show, new soon to be professional MLSs is that framework you just talked about, right? So I can show them how to diagnose Babesia through the classic Maltese cross or those trophozoites at right angles, but then you have to talk about malaria now and how that can be confusing there. But certainly moving into that serological profile, I always tell my students that and alumni that keep in mind that usually you're thinking about that in terms of like circumstantial evidence until it becomes really critical later in the infection. So important, I think, that the general public doesn't think about acute infections versus what's happening later and kind of what that means in the world of everything that's happened since the pandemic. So many in the public will think they kind of are understanding certain things about antibodies and antigens, and I just think these are always fascinating things to talk about even in the public sphere. What are the main limitations do you think clinicians should understand when relying, you just talked about this, when relying on serological testing for tick-borne diseases, particularly during that acute phase? What specific things do you think they should be thinking about?
Yeah, I think there's two things. Across the board, they need to think about the timeline of the infection for the patient that they're seeing. So if it's just a few days since symptom onset, it's unlikely that antibodies related to this acute presentation are going to be robust and generated, and that could potentially lead to a false negative result, right? Let's use Lyme disease as the example because we don't have a lot of other great alternatives to serology. We know that in the acute phase of Lyme disease, even with the improvements of the antigens and synthetic antigens and this multi-step process, the sensitivity in the acute phase for Lyme disease is still just 60 to 70%. So it leaves a good window of potentially infected people where they're going to have a false negative result. The same is true for really all the other tick-borne diseases that have serologic diagnostic options like Anaplasma, Ehrlichia, Babesia, etc. So you need to just be aware that if your patient is presenting like they have a tick-borne disease and they have the appropriate exposures or it's the right time of year or whatever additional factors, that a negative serologic test in the acute phase does not rule out any of the possibilities. And I think it's important that clinicians, as I think that they do, and the guidelines suggest that with significant suspicion, they should treat for these tick-borne diseases no matter what, because the potential negative impact of, say, doxycycline for a few days is a lot less than the impact of missing a tick-borne infection in the acute window and not following up, and then somebody has a much worse outcome than they needed to have. So that's the first part. I think the second part that we talk about a lot more here on the inpatient side and maybe is even more foreign to the average ordering provider is immune status and patient immune sort of complexity or completeness, right? So let's use a tick-borne diseases or a tick-borne virus as the example, say Powassan virus. Largely, we use the serologic options for patients that are presenting to the hospital because they don't normally present in their acute viremic window, which is just like a non-specific febrile illness window. By the time they're coming to the hospital, they have those uncommon but severe manifestations of neurologic disease. And we know that in a normal sort of viral kinetics of infection, by the time they're entering that CNS phase, they're already outside their viremic window. There's really no virus in the spinal fluid or in peripheral blood or something to do PCR on. So we lean on serology in what is, I would guess you would think of as an acute CNS infection, but really it's a later manifestation of that that organism. But the caveat is that in immunosuppressed individuals who may be at more risk when they get infected of not clearing their virus and presenting in that neurologic phase, they're probably not mounting antibody responses in a normal way. Therefore, your serologic tests are not going to perform as expected. And really, you do look to the molecular methods in that later manifestation window, because those patients are likely to have remaining viremia and they have not cleared their virus, and the test performs a lot different in these two different populations. So I think that's a really big key too, is that we can tailor our diagnostic choice not only by what we think the normal trajectory of the disease course is, but also by how the patient factors influence the changes in how test performance and also the disease characteristics.
Right on. It's always, from a microbiologist standpoint and former public health person, it's kind of like this really strange and fascinating and diabolical nature how the pathogen, can flip-flop on that evasion technique. Like if you don't have great suspicion, as you mentioned, as a clinician, I guess this falls back into the clinician realm. And with that in mind, this kind of comes to mind. How are these emerging technologies like metagenomic next generation sequencing? And we're seeing this a lot, right? AI assisted microscopy changing the landscape of kind of diagnosing vector-borne diseases and really a lot of diseases, right? It's really changing how the algorithms are put together with respect to these kind of outside of the normal realm of diseases.
Yeah, I'll tackle them separately. So
Okay.
next-gen sequencing, particularly the unbiased version of metagenomics, newly emerging in the vector-borne disease state. I think it has a couple good, really good advantages. So one is we've talked about, it's tough to pick all of the right tests and you don't want to miss something. So one of its benefits is that it's agnostic. So theoretically, if there's a tick-borne pathogen in a sample, it can detect it. So it does sort of cast that broad net that if you find yourself ordering a large number of individual tests, maybe something bundled like this is really potentially a great future solution, right? Where you can collect all of those things and more in one diagnostic test. I think the other thing is that I bet we're not done discovering the vector-borne illnesses that are around, particularly the viruses,
Would
right?
bet on that myself for sure.
So there's things that probably that we just have not had tests for that would explain a otherwise undetermined febrile summer illness, right? That are probably vector-borne infections. And I think the idea of using metagenomics to detect those novel or rare organisms is very interesting. And then lastly, it overcomes some of those patient factor issues. Is if you don't know someone's immune status and you want to, it can really detect anything that's in the sample, right? So it theoretically can overcome that challenge as well. The sort of knock on it is that it's still a direct detection method. And if the patient is presenting with a arbovirus and that virus is already cleared and most of what they're experiencing is a post-inflammatory syndrome type thing, this very fancy method is not going to overcome the fact that that viral nucleic acid is not present. So it has technical limitations to as we talked about, the kinetics of the viral infection that it's just never going to overcome. But yeah, I think the idea of using advanced molecular diagnostics to broadly assess someone for a vector-borne disease is really exciting. And as it becomes more accessible, as it's cheaper, as it's more easily packaged and something, I think it'll be more widely used in
Almost
this
like
context.
almost like a screening test, right? With some limitations, obviously, around the patient's history.
Yeah, I think it can be really useful in the way that we can not fear missing something in the future.
Right.
I mean, of course, we need to know that molecular tests only work when and where they work, but instead
Right.
of ordering 10 of them, maybe we can just order one of them.
Right.
And then AI assisted microscopy. This is super exciting. I still think that microscopy for Babesia is the best diagnostic option. But maintaining that skill, first of all, is becoming
Right.
more and more challenging. And what contributes to some of that challenge is a lot of places, depending on, how how rural or how or patients they see, or how much Babesia is around them. Usually most of the stuff you look at is negative, right? And then you might see one positive or a few positives a year, and
Right.
really maintaining that familiarity becomes a challenge by just basically supporting it through proficiency testing. So I think it's a tough skill to maintain. Two, it's very labor intensive, right? To sit down and read a blood film and confidently call it negative, it takes a little while. And so your throughput is limited simply because the technologist needs to use their skill to assess that slide. And it's going to take them a little while to get through those. And as health systems become more consolidated and volume flows through what was tiny parasitology laboratory, and now they're asked to do more and more, it's overwhelming to think that we can perform microscopy for everybody that has a suspected Babesia, malaria, etc. So I think this is one place where the AI assistance can really help us. It can likely filter through and screen through dramatically more slides than an individual technologist can do by hand. And secondly, if it gets rid of all the negative slides, which is going to be the bulk of them, it
Right.
really relies on the skill of the parasitologist for the most important part, which is the identification, confirmation of what the AI thinks is there, some confirmation of the percent parasitemia and things like that. And I think that gives, in my opinion, the technologists a lot more value. They're using their skills at the top, right? They're
Right.
really taking advantage of all the stuff they know about how to differentiate Plasmodium species and making sure that it's right. Instead of spending 7 of the hours a day looking at negative
Right.
things,
Negatives, right.
and theoretically, they could use their saved time by not screening all of those negative slides on other high value things. Um, so I think as we're always asked to do more with less, I think we can use the AI to cut the sort of lower value things out of our work, and really improve efficiency, possibly, hopefully improve the morale and satisfaction of our technologists, and then get them to do some other exciting stuff.
Right on, right on. I love that you brought that up because as someone who educates future medical laboratory scientists as well as DCLSs, people that are at that kind of higher level of the career spectrum, their expertise is being able to look at those suspicious, possibly positive, maybe false positive, and if we have a way, and it's already happening, right? AI assisted microscopy. Many companies are selling automated analyzers now that look at hundreds of blood smears now that can really help you in a way, as we mentioned earlier, screen out
Mhm.
it's the negatives for our audience. I mean, there's so many negatives that just take up time and you can't take them lightly. And so you're really drilling down and trying to make sure you're doing a great job. But if you can roll out 60, 70% of that in a way that is strongly negative, and then you can move on to those ones that we're really, really concerned about. So absolutely agree. I think it's going to be a workload issue. It really helps with workload, which helps workforce shortages, which is part of our world in the laboratory and many other places. So I appreciate your attention to that. Uh, Given the regulatory uncertainty surrounding this is a big catchphrase this year surrounding laboratory developed tests, LDTs. What challenges do clinical and medical laboratories face when implementing molecular diagnostics for tick-borne pathogens?
Yeah, huge win last May with
Right.
the striking down of the FDA's proposed rule. Um, as a director of a laboratory that implements a lot of LDTs, I oversee a development team. We fill diagnostic gaps just for some of these reasons, tick-borne
Right.
diseases, but other things. I think, laboratories being able to provide really high quality tests that they develop themselves to serve their specific patient populations is paramount, right? I
It's
mean,
huge. Yeah.
we really, I think there's a huge underestimation about just how valuable, regularly used, and important those tests are. And
Right.
tick-borne pathogens are a great example. To my knowledge, there's not a single molecular test that's FDA approved for a tick-borne pathogen.
Right.
And so all of the optimal acute phase diagnostics that rely on molecular tests are being performed by labs that have implemented LDTs. Um, it's a huge gap. I think that the challenge that laboratories face is whether or not they are resourced appropriate to be able to do that. And it creates a disparity amongst the laboratories and ultimately impacts patient care, right? And not a knock on either side. It fully appreciate that to be able to offer an LDT, you probably are enjoying some level of resource that others do not always have.
Right. Right.
But the reality is that these diseases are transmitted everywhere. And you, as we mentioned much earlier, you can't predict where a patient is going to enter a health system. A lot of exposures occur with environmental exposure, which largely means that patients may be in a more rural area. And you could think that the access would be maybe more important to have in that point of original presentation, depending on what health system or access to care that person has. So I think it's a huge challenge that these are limited to larger laboratories that are able to themselves reference laboratories
Right.
that, while they provide greater access, increase the time to result because there's an unavoidable shipping of the sample that has to occur.
Right.
But I think
Right.
the biggest challenge is that it's just not something everyone can do. And I would love to see some advancement on the FDA approval side where there's cartridge-based or kit-based or some
Right.
sort of test that can be put out that is more approachable and amenable to the average laboratory.
Right.
Um, for those people that can do LDTs, the uncertainty, uncertainty is a good word, right? I think we feel relatively comfortable by the language in the ruling that FDA does not have oversight, and it would be tough for them to challenge that in the future. But there has been an attempt to regulate laboratory developed tests every couple of years for the last
Right.
25 years. This will not be the end of potential changes to LDT regulation. And there are some reasonable arguments for why we may need a different regulatory system. There are examples where the LDT current situation has failed, where there's been poor tests that have made it to market or bad laboratories. But again, to stress that is such a vast minority compared to
Right.
what is
Right.
available. So I'd say for the folks that develop lab tests, I think we're keeping our eyes and ears open. I think this is a really great opportunity where we made strong statements over the last couple of years and provided really great evidence for the value of these tests and how we can generally regulate ourselves through the existing structures. And there may be room for improvement, but we should really be there at the table trying to dictate what that improvement
Right.
is. I think that our voices as experts is really important at this juncture. So when we do see the next version of what a proposal looks like, it looks practical, it looks approachable, it looks like it actually achieves the goal that's trying to achieve, right? We need to keep the patient quality and safety at
Right.
the focus of this and remove sort of the extra burden items that don't actually get at that common goal. So I think the uncertainty for us is really just to, keep being advocates for
Right.
LDTs and also being ready to answer, what would an appropriate regulatory pathway look like if there needs to be any change.
Yeah, totally agree with you. I think, over my 3 decades of kind of in the public health and medical laboratories kind of environment, I think that sometimes the subject matter experts, take for granted what you just talked about. I think we absolutely have to be at the table, maybe more than we've ever been comfortable doing. We really need to step into that area. If we don't speak up, right, somebody will. And we certainly have seen that happen over the last, 5 or 10 years. So, what sometimes happens in my past, you end up with deserts, like you have deserts in the United States alone, that if someone is suspected of a certain illness, they may not have a specimen get to an actual laboratory that can perform an LDT for days, right? And so I know in Texas we're so big that I was part of creating a regional reference lab for rabies variants, which is sometimes challenging for people to understand what's going on, but it's not enough. Like you almost need one in every state, or at least geographically situated, and then have good communication with clinicians to how to utilize those facilities for sure. So I really appreciate your thoughts around that particular topic. Are there any other important takeaways or any things from your insight around the clinician and diagnosing vector-borne diseases that we haven't talked about that you would like to share today?
I don't think there's anything that we haven't talked about. I just will stress like the collaboration and the relationship part has been the most important thing here. I think that providers want to order the best test for their patient. They picking them in a really complex milieu of tests and patient factors, et cetera. I hope we've outlined is really challenging in the vector-borne realm. But what I've found over my last few years here is that, reaching out and asking, what challenges do you experience when you're ordering, and how could we put some sort of, structure together that could alleviate some of those for you, has been really valuable. We've found better quick panels, better organization of what people add to their preference list, better information where they realize like, oh, I did not understand the performance caveats to that test, and I've been ordering it inappropriately forever because I just didn't know where it really performed best. I think we need, just as you mentioned, stepping out of our comfort zone. I would stress and encourage people that that they need to get out of their comfort zones and talk to people about the optimal ways to diagnose tick-borne diseases. That'll be the easiest first step. When we all get these fancy AI integration tools and we can take that expertise and plug it into the EMR, that will be even better. But right now, I think it's the old school know your neighbor on how they're and what challenges they're facing, and see if you can help sort of alleviate some of them.